Hello everybody, allow me to introduce myself. This is Professor Triple Nick or Nick PA from Brooklyn, New York. If you would like to contact me, the best way is through my email, which is NICK, M like Maddie, D like dog, the number 1 at gmail.com. Let's talk about neurology, board review notes for mid-level providers, which includes PAs and NPs. Let's start with stroke. By definition, stroke is a sudden onset of neurological deficit from a death of the brain tissue. Stroke is the third most common cause for death in the United States. The risk factors for stroke includes those of MI or myocardial infarct, hypertension, diabetes, hyperlipidemia, tobacco smoke. Etiology. Stroke is caused by sudden blockage of the flow of the blood to the brain in 85% or by bleeding in 15%. A cerebral vessel is blocking either by thrombus, which occur in the vessel, or by embolus to the vessel. Emboli originate from two places, heart and carotid stenosis. Heart, this is caused by AFib, valvular heart disease, or DVT. And there is so-called PFO, or patterned foraminovalle, which brings the paradoxical emboli to the brain. The presentation is, let's talk first for MCA stroke or middle cerebral artery stroke in 90% of the cases. This is 90% of the cases of stroke. Patient presents with weakness or sensory loss of the opposite contralateral side of the lesion, which causes stroke. Let's go to the next slide. Also presents with homonymous hemianopsia, which is basically loss of visual field of the opposite side of the stroke. Left-sided MCA strokes results in a loss of the right visual fields. The eyes cannot see the right side, so the eyes deviates to the left. So the eyes deviates opposite to the stroke. Hence, the eye looking the site of the lesion. Also presents with aphasia. Aphasia, if the stroke occur on the same side as the speech center. In 90% of the patients, this is the left side. Speech is controlled by the same side as handedness. Right-handed people or left-dominant brain have a speech center on the left-handed side of the brain. In case of anterior cerebral artery or ACA stroke, we have a personality cognitive defects such as confusion. Number 2, urinary incontinence. Number 3, leg more than arm weakness. If we have so-called posterior cerebral artery or PCA stroke, we have ipsilateral sensory loss of the face, 9th and 10th cranial nerves, contralateral sensory loss of the limbs, and limb ataxia. Diagnostic tests. The best initial test for any kinds of stroke, this is CT scan of the head without contrast. The most accurate test, this is MRI. CT scan is done first, then this is the most sensitive test for stroke, but in order to exclude hemorrhage, as it can cause stroke prior to initial treatment, CT scan needs 4 to 5 days to reach greater than 95% sensitivity. MRI needs only 24 to 48 hours for 95% sensitivity. In many places, they are using thrombolytics up to 4.5 hours after the onset of stroke. Let's go to the next slide. On this slide, we see figure 10/1, non-hemorrhagic stroke, which is characterized with brain edema without blood. The treatment. The best initial treatment for non-hemorrhagic stroke is, number 1, less than 3 hours from the stroke, thrombolytics, more than 3 hours since the onset of stroke, aspirin, and number 3, hemorrhagic stroke, nothing. If the patient is already on aspirin at the time of the stroke, the answer is add dipyridamole or switch to clopidogrel. Hemorrhagic stroke has no treatment to reverse it. Surgical drainage will not help outside posterior fossa. Let's go to the next slide. Here we have an algorithm how to handle likely ischemic stroke on figure 10/2. If it is less than 3 hours from the onset of symptoms, look at the left side of the algorithm. The treatment considered plasminogen activator if no history of bleeding. If it is more than 3 hours of the onset of the symptoms, the treatment is aspirin or add dipyridamole or switch to clopidogrel if already on aspirin. And then perform further studies to assess etiology. And number 3, if the symptoms are less than 24 hours, then resolve. This is so-called transient ischemic attack. The treatment for prevention of stroke is either aspirin or clopidogrel. Do not combine them. Combine them only to add bleeding. You cannot combine dipyridamole with aspirin as equivalent of clopidogrel. Thrombolytics can sometimes be used up to 4.5 hours after the onset of symptoms. Thrombolytics are the standard of care. So the treatment for prevention of stroke is either aspirin or clopidogrel. Do not combine them. Combination of both of them can cause bleeding. You can combine dipyridamole with aspirin as equivalent of clopidogrel. Thrombolytics are sometimes used within 4.5 hours after the onset of symptoms. Thrombolytics are standard of care under 3 hours since the onset and are FDA approved for this use. The time range from 3 to 4.5 hours after the onset of symptoms is considered experimental, and informed consent must be obtained in writing. Patient comes after 4.5 hours. We have the clot removed via catheter. Catheter retrieval pulls the clot out like a corkscrew. It is used up to 6 to 8 hours after the stroke, but angioplasty is not. Angioplasty would be a rupture of the vessel, so statins. If we have patient with stroke, we need to give statins. Let's go to the next slide 5, showing on figure 10.3 CT scan of the head with acute blood, which appear white on the CT. Contrast is not needed to detect blood. Every patient with a stroke should be started on statin medication. Regardless of LDL. Although target-based therapy for lipid management is unclear at that time, we want to bring the LDL less than 70. The main point is exam will show you a stroke or ask what to add. How we evaluate the causes for stroke and their treatments. We do an echocardiogram. And number 1, this is surgical replacement or repair of certain damaged valves. For thrombi, we do heparin 4 by coumadin of INR of 2 to 3, rivaroxaban and dibigatran are alternative medication. Also, there is a PFO evaluation or pattern foramen ovale for paradoxical MOI. There is a clinical clinical wisdom, which says that stroke patients should be placed on telemetry to detect AFib or A-flutter. Basically, on slide 6, it states that we need to anticoagulate everybody. We can use also EKG. We'll find arterial fibrillation on flutter, which is treated with NOAC or warfarin as long as the arrhythmia persists. Stroke or TI means that CHAD/VAS score of at least 2. Holter monitor, we do 24 to 48 hours ambulatory EKG. If the initial EKG is normal, the Holter monitor should be performed to detect arterial arrhythmias with greater sensitivity. Also, we can do is a carotid duplex ultrasound. Carotid stenosis is a frequent cause for MOI to the brain. If the patient has symptomatic CV disease or more than 70% stenosis is detected, surgical correction of the narrowing should be performed. Endarterectomy is superior to carotid angioplasty. Endarterectomy has no value for mild stenosis under 50%. It is unclear if endorectomy will benefit moderate stenosis from 50 to 70%. If the stenosis is 100%, however, intervention is not needed. There is no point of opening a passage which is 100% occluded. So carotid angioplasty and stenting is no proven value for stroke patient. It is always the wrong answer. On the PANP boards, you stay away from controversial and unclear areas such as management of moderate carotid stenosis between 50 and 70%. Your question will be clear. Definitively operate for more than 70% and do not operate for less than 50%. We need to control the risk factors for stroke. Such as diabetes, a hemoglobin A1C supposed to be less than 7%. We need to control the hypertension. We need to reduce the LDL for less than 70. And the tobacco smoking needs to be stopped. There is a clinical tip which states that carotid stenosis is considered equivalent of coronary artery disease, so control the LDL for less than 70 milligrams per deciliter. Let's talk about headaches. What is the most likely diagnosis? So we are on slide 7. Tension headaches by far is the most common cause of headaches. It's a diagnosis of exclusion. You must exclude, number 1, migraine, which can cause visual disturbances like flashes, sparks, stars, hallucination, photophobia, aura, relationship to menses, and association with food, chocolate, red wine, cheese. Also can be precipitated by emotions and associated with nausea and vomiting. Cluster headaches, frequent short duration, high intensity headaches with 10 times men affected 10 times more than women. Giant cell temporal arteritis presents with visual disturbances, symptomatic leak. Giant cell or temporal arteritis presents with visual disturbances, systemic symptoms such as muscle pain, fatigue, and weakness, also jaw claudication, and so-called pseudotumor cerebri associated with obesity, venous sinus thrombosis, oral contraceptive, and vitamin A toxicity. Mimic a brain tumor with nausea, vomiting, and visual disturbances. Physical exam. So physical exam for tension headaches, no physical findings. Migraine, usually no physical findings, but rare. You can see aphasia, numbness, dysarthria, or weakness. And for cluster headaches, you can see a red, tearing eye with rhinorrhea, Horner syndrome, occasionally. For cluster headaches, you have, as we said, red tearing eye with rhinorrhea, Horner syndrome occasionally. And for giant cell temporal arteritis, we have visual loss, tenderness on the temporal area, For pseudotumor cerebri, we have pupil edema with diplopia from 6 cranial nerve, which is abducens palsy. So basically, every patient which has a glaucoma, we need to evaluate glaucoma with headache and red eye. Diagnostic test. For tension headaches, migraine, and cluster headaches, we have no specific tests. Head CT or MRI is done to exclude So for tension headache, migraine, and cluster headaches, there is no diagnostic test. Head CT and MRI are done to exclude intracranial mass lesions. And if the diagnosis is unclear or the syndrome is recently started, there is no need to perform imaging if there is no clear history of headaches of a particular type. Pseudotumor cerebri, the diagnosis cannot be made without a CT or MRI to exclude the intracranial mass lesion or a lumbar puncture LP showing increased pressure. Only the pressure is abnormal, the CSF itself is normal. So only the pressure is abnormal. Clinical tip, it is critical to start steroids without waiting for biopsy of giant cell arteritis. Giant cell arteritis is associated with marked elevated ESR, and is the most accurate test is the biopsy. Treatment. Different type of headaches is treated differently. Tension headaches, we need to give NSAIDs or other analgesics. For migraine, triptans or ergotamine as abortive therapy. For cluster headache, triptans, ergotamine, or 100 oxygen as abortive therapy. And for giant cell temporal arteritis, we need to give prednisone. And for pseudotumor cerebri, we need to do weight loss, acetazolamide to decrease production of cerebrospinal fluid. Steroid will help. Repeat lumbar puncture. We need to repeat the lumbar puncture rapidly, and this will rapidly decrease the intracranial pressure. After that, we need to place VP shunt, or we need to fenestrate, cut into the optic nerve if medical therapy does not control it. Let's go to the next slide, number 9. Let's talk about abortive therapy for migraine and cluster headaches. Both of these can be rapidly interrupted by either ergotamine or one of the triptans. Example, sumatriptan, elatriptan, amitriptan, zomitriptan. The main difference is that 100% oxygen, prednisone, and lithium are effective at interrupting the cluster headaches, but not the migraines. Provide cluster prophylaxis with verapamil. Prophylactic or preventive therapy for migraine. Patients experience 3 or more migraines per month should be started on treatment for them. The most preventive therapy is propranolol. Other preventive medications are calcium channel blocker, TCA or aminotriptyline, SSR or the pyramid, and number 5, other preventive medications are, as we said, calcium channel blocker, tricyclic antidepressant, or amitriptyline, SSR, topiramate, and botulinum toxin injections. Since the cluster headaches happen in short bursts, that's why it's called cluster, and then resolve for months or years, preventive therapy is not clear. All forms of preventive therapy take several weeks to begin to work, and cluster has usually so all the forms of preventive therapy take several weeks to begin to work, and the cluster has usually resolved by the time they would be effective. On this table, there is we're talking about presentation, type, treatment, and prophylaxis of 3 different types of headaches. Let's start from the beginning. Number 1, left to right. Number 1, this is tension headaches. Tension headache presents with bilateral band-like pressure lasting 4 to 6 hours, normal physical exam. The treatment is NSAIDs or acetaminophen. For migraine, number 2, or in the middle, migraine headaches, they present with plus minus aura photophobia. It's related to food, emotional, and menses. Rare aphasia, numbness, and dysphagia. Treatment is avoid triggers, NSAIDs, and 5-ATA1 agonist. The treatment is, as we said, avoid triggers, NSAID, or triptans, 5-HT1 agonist. If we have 3 attacks per month, we can use propranolol or sodium valproate. For cluster headaches, they present with episodic pain, unilateral periorbital intense pain, lacrimation, eye redness, nasal stiffness, and lithptosis. The treatment is sumatriptan, number 2, octreotide, number 3, so for the last one, cluster headaches, treatment is sumatriptan, octreotide, and oxygen. And if this doesn't help, we do prophylaxis with verapamil, prednisone, and sodium valproate. Let's go to the let's discuss trigeminal neuralgia. This is again Dr. Nick or Professor Triple N from Brooklyn, New York. Trigeminal neuralgia, it is unimproved by meds, which is unimproved by medications, needs gamma knife surgery. This is a clinical fact. Basically, trigeminal neuralgia is an idiopathic disorder of the 5th cranial nerve, or cranial nerve 5, which result in severe overwhelming pain in the face. Attacks of pain can be precipitated by chewing, touching of the face, or pronouncing certain words, which the tongue strike the back of the front teeth. Patients describe the pain as feeling as if a knife is being struck into the face. There is no specific diagnostic test. Treat with oxcarbamazepine or carbamazepine, baclofen, and lamotrigine also can be effective. So the main line of treatment is oxcarbamazepine or carbamazepine. If the medication does not control the pain, gamma knife surgery or surgical decompression is curative. Treatment of the diagnostic test for seizures, EEG would not be the right answer unless all these tests are done and ways the normal, including a CT or MRI of the head. There is no point of doing EEG if to identify the cause of seizure if there is a clear metabolic toxic or anatomical defect which caused the seizure. You have always found the cause of the seizure. Let's discuss the next topic, which is delirium, stupor, and coma. These terms represent variations of the spectrum of abnormalities of altered consciousness or unresponsiveness to stimuli. All of the metabolic, toxic, and CNS anatomical problems previously listed can cause confusion, and or difficulty with arousal, described as delirium, stupor, obtundation, or coma. When the condition is severe enough, a seizure occurs. Confusion is to coma and seizures as angina to a MI. This is a clinical fact, is that seizures with unclear etiologies are called epilepsy, and if there is a clear reason, it is not epilepsy. Treatment of status epilepticus. There is only seizure treatment that is truly clear. The best initial therapy for present seizures is a benzodiazepine such as lorazepam and diazepam IV. If the seizure persists, then give a phenytoin or foscarnet intravenously. If the seizure persists, then give of course, phenytoin or fosphenytoin So both phenytoin or fosphenytoin have the same efficiency, but fosphenytoin has a few side effects compared with phenytoin, like lidocaine, and fosphenytoin has few side effects compared to phenytoin, like lidocaine. Phenytoin is a class 1B antiarrhythmic medication. If given IV, it is associated with hypotension and IV block. Let's talk about treatment of status epilepticus. Is when there is only seizure treatment which is truly clear. The best initial therapy for persistent seizure, this is benzodiazepines such as lorazepam or diazepam IV. If the seizure persists, then we need to give phenytoin or fosphenytoin. Fosphenytoin and phenytoin have the same efficiency, but fosphenytoin has a few side effects compared with the phenytoin. Like lidocaine, phenytoin is a class 1B antiarrhythmic medication. When given IV, it is associated with hypotension and IV block. Fosphenytoin does not have this side effect and can be therefore given more rapidly. If benzodiazepine and fosphenytoin do not stop the seizure, then we need to administer phenobarbital. Finally, the ultimate therapy for unresolving seizure is to use a neuroblocking agents such as succinylcholine, vecuronium, or pancuronium to allow you to intubate the patient and then given anesthesia like midazolam or propofol. The patient must be placed on ventilator before the administration of the propofol, which can stop the breathing. And there is a clinical fact here which we need to remember, is that neuromuscular blocking agent such as succinylcholine do not stop the seizure. They just stop the muscular contraction or the external manifestation of the seizure. Classification of seizure disorder is the next topic. Basically, the seizures are divided in partial seizures, tonic-clonic seizure, and absence-ptimal seizures. Partial seizures. Let's start from partial seizures. Partial seizures, like the name applies, this is a seizure that's focal to one part of the body. For instance, a patient may have a seizure that's limited just to the arm or to the leg. Partial seizures can either be simple intact consciousness, or complex loss or alteration of consciousness. The other type of seizure, this is a tonic-clonic seizure. This is a generalized seizure which varies phases of muscle rigidity, tonic followed by jerking of the muscle of the body for several minutes, clonic. Absence petit-mal seizure, this is where the consciousness is impaired only briefly. The patient often remains upright and gives a normal appearance or seems to be staring into space. Absence seizures occur when mostly often in children. Let's talk about the treatment of status epilepticus. We know that status epilepticus is medical emergency, and we have few options here. Number 1, benzodiazepine. Number 3, fosphenytoin. Number 3, phenobarbital. The last one, number 4, general anesthesia. Let's discuss the treatments and anti-epileptic drugs. Let's start with the indication for treatment. It is not necessary to begin anti-epileptic drugs for a single seizure. The exceptions in which you should start after a single seizure are: number 1, presentation of status epilepticus or with focal neurological signs. Number 2, abnormal EEG or lesion of the CAT scan. Number 3, family history of seizure. How we choose the anti-epileptic drugs. The treatment of status epilepticus is clear. The best treatment for epilepsy is not clear. A number of medications are effective, but none is effective superior to the others. In other words, levetiracetam, phenytoin, valproic acid, and carbamazepine all are near equal efficiency. You cannot be asked to choose between them based on the efficiency. Keppra has the fewest side effects. And we need to know here that an alternative treatment is with gabapentin, topiramate, lamotrigine, oxcarbazepine, and levetiracetam. Exoximide is the best therapy for absence seizures. If seizures are not controlled with a single agent, alternative medications should be tried. If seizures are still not controlled, adding a second drug may help. If multiple medications do not control a seizure, surgical correction of the seizure focus may lead to resolution of the recurrences. Alcohol withdrawal seizures are not treated with long-term anti-epileptic seizure. Definition etiology of subarachnoid hemorrhage. SAH or subarachnoid hemorrhage is caused by rupture of aneurysm that is usually located in the anterior portion of the circle of Willis. Aneurysms are 2% of the routine autopsies. The vast majority never rupture. They're most frequently in those with the following clinical conditions: polycystic kidney disease, tobacco smoke, hypertension, hyperlipidemia, high alcohol consumption. Let's go to the next slide. What provokes a rupture is not clear in majority of cases. What is the most likely diagnosis, if the question asks? You have to look for a sudden onset of extreme severe headache with meningeal irritation, stiff neck, photophobia, and fever. Fever is secondary to blood irritations of the meninges. Loss of consciousness occurs in 50% from the sudden increase of intracranial pressure. Focal neurological complications are about 30%. How the SAH differ from meningitis? Number one, it's a very sudden onset. Number two, loss of consciousness. What is the diagnostic tests? The best initial test, this is CT without contrast, which is 95% sensitive. The most accurate test, this is lumbar puncture, which showing blood. Xanthochromia is a yellow discoloration of CSF from the breaking of the red blood cells in the CSF. LP is necessary only 5% if you have a false negative CT scan. The CSF in subarachnoid will have an increased number of WBCs, which can mimic meningitis. However, the ratio of WBCs to RBCs will be normal in subarachnoid hemorrhage. When the WBCs count exceed the normal ratio, you should suspect meningitis. Clinical tip is here is the normal ratio is 1 WBCs to every 500 or 1,000 RBCs. Let's go to the next slide. On a figure 10/4, we can appreciate head CT without contrast with detected SAH, and in this case the lumbar puncture is 100% sensitive. Also, what about the electrocardiographic finding in the intracranial bleed? There is here a clinical tip that the contrast CT or MRI improves detection of mass lesions such as cancer or abscess. Do not use contrast when you're looking for blood. Also, we need to know that an EKG may show large or inverted T wave suggestive for myocardial ischemia, which is so-called cerebral T waves. This is thought to be from excessive sympathetic activity. Angiography is used to determine the site of the aneurysm in order to guide repair of the lesion. The diagnosis of subarachnoid hemorrhage is based on CT and sometimes LP. The only way we can tell precisely what vessel rupture it is a CT angio. So every patient which has a subarachnoid gets a CT angio, which is a standard angiogram with a catheter or MRA. Let's go to the next slide, which is slide 18. In the beginning of the slide, we talk about that in 50 to 70% of those patients which rebleed, they'll die. Let's discuss the treatment for subarachnoid hemorrhage. There is no treatment which is able to reverse the hemorrhage, but we have a couple of treatment options. We can give the patient nimodipine, which is a calcium channel blocker, which prevents ischemic stroke, sequential ischemic stroke. We can do embolization or coiling, which is use a catheter to clog up the site of bleeding to prevent of repeated hemorrhage. Also, we need to know that embolization is superior to surgical clipping in the terms of survival and complications. Also, we can do number 3 is so-called ventricular peritoneal shunt. And in this case, the subarachnoid hemorrhage is associated with hydrocephalus. We need to place a shunt only if the hydrocephalus develops. And also we need to, fourth treatment option is seizure prophylaxis. And usually phenytoin is generally given to prevent seizures. And if the question asks, which of the following is indicated, anti-epileptic therapy is the answer, although it is controversial. Also, this slide, there is a clinical tip which states that why tell you about surgical clipping if embolization is better choice, when the truly right treatment, embolization, is not one of the choices. You choose the most closest to the right. Here also we have a clinical vignette, which is about a woman comes to the emergency department with severe headache starting one day prior to admission. The physical exam she had, it is a temperature of 103 Fahrenheit, nuchal rigidity, and photophobia. Her head CT is normal. LP shows CSF of 1,250 white blood cells and 50,000 red blood cells. The question here is, what is the most appropriate next step of management of the patient? Number 1, angiography. Number 2 or B, ceftriaxone and vancomycin. Number C is nimodipine. Number D is embolization. E is surgical clipping. Let's go to the next slide. Slide number 19. F is a repeater CT with contrast, and G is a neurosurgical consultation. The right answer here is B, and the explanation behind this answer is that the number of WBCs in the CSF in this patient far exceeds the normal ratio of 1 WBC per each 500 or 1000 RBC. With 50,000 RBC, there should be no more than 50 to 100 WBC. The therapy, the presence of 1250 WBC indicates an infection, and ceftriaxone and vancomycin are the best initial therapy for bacterial meningitis. Contrast is not useful when looking for blood. Try never to answer consultation for anything. And there is a clinical tip here which states that consultation is the right answer only when you want to be a particular procedure, to do a particular procedure, and the procedure is not given as a choice. If the right answer is embolization and is not listed, but interventional neuroradiology consult is one of the choices, then the right choice in this case is consult. Let's continue to the next topic, which is spine disorders. We'll discuss first is anterior spinal artery infarction. Anterior spinal artery infarction presents with the following. Number one is loss of all function except for the posterior column, which is position and vibratory sensation, which are intact. Number two, flaccid paralysis below the level of infarct. Number three, loss of DTRs or deep tender reflexes at the level of infarction. 1, 2, and 3 are the most important clinical signs. But then we have 3 more, which is 4, evolves into spastic paraplegia several weeks later. Number 5, loss of pain and temperature. Number 6 is external plantar response. So for this case, there is no specific therapy. Let's talk about subacute combined degeneration of the cord. This clinical scenario presents with number 1, from B12 deficiency or neurosyphilis. Let's go to the next slide, which is slide 20. And also presents number 2 with positional and vibratory sensation, which are lost. Let's talk about spinal trauma. In this clinical situation, we have acute onset of limb weakness and or sensory disturbances below the level of the injury, with severity in proportion of the degree of injury. The most important is that the sphincter function is impaired, loss of DTRs at the level of the injury, followed by the hyperreflexia below the level of the trauma, and we can treat it with glucocorticosteroids. Then there is another clinical situation, which is Brown-Séquard syndrome. This is after unilateral hemisection of the spinal cord from an injury such as knife wound, cutting half of the cord, or compression from a mass lesion. Patient loses pain and temperature on the contralateral side of the injury, and also this is the most important. So patient loses pain and temperature of the contralateral side, and loses also motor function, and as well as positional and vibratory sense of the ipsilateral side of the injury. And this is number 2. So we have 2, which is positional and vibratory sense, loss of ipsilateral side of the injury. If there is a mass, surgically we have to decompress. Next topic, this is syringomyelia. By definition, syringomyelia is a fluid-filled dilated central canal in the spinal cord. This widening of the bubble or the cavitation first damages the neural fibers which passing near the center of the spine. It is caused by tumor or severe trauma to the spine, or is congenital. If the question asks what is the most likely diagnosis, we need to look for loss of pain and temperature bilaterally across the upper back and both arms. This is the most important. Loss of pain and temperature bilaterally across the upper back and both arms. Also, we need to look for phase cape-like distribution of the defects. Syringomyelia is literally a bubble in the cord. Also can cause loss of reflexes and muscle atrophy in the same bilateral distribution. Let's go to the next slide, which is showing on the figure 10/5 case of syringomyelia with a fluid-filled lesion inside of the center of the cord, resulting in a cape-like distribution of sensory loss across the neck and upper extremity. The diagnosis is MRI, which is the most accurate test. The best treatment is surgical removal of the tumor if present and drainage of the fluid from the cavity. Next topic will be a brain abscess. By definition, a brain abscess is collection of infected material within the parenchyma of the brain tissue acting as a space-occupying lesion. The brain abscess, the most important, is that can spread from continuous infection in the sinuses, mastoid cells, and otitis media. Anything which can lead to bacteremia can allow infected material to bulge in the brain. Also, pneumonia and endocarditis cause bacteremia, which cause bacterial abscess. Let's go to the next slide. In this slide, let's start with the picture. On figure 10/6, we can see that we have both cancer and infection enhanced with contrast. Basically, you cannot distinguish them based on the CT scan appearance. Here, we need to look for headaches, nausea, vomiting, fever, seizures, and focal neurological finding. The presentation is somewhat non-specific, and there is no way to distinguish a brain abscess from cancer without biopsy. Cancer can give you fevers also. The diagnostic test, the best initial test, this is a head CT or MRI. The most accurate test is brain biopsy. Scan of the brain shows a ring or contrast enhancing lesion that most likely have a surrounding edema and mass effect. Cancer and infections are indistinguishable based on the imaging study alone. Also, we have to know that CSF will be unlikely to be helpful, even if you are obtained, and LP is contraindicated because of the possibility of herniation. Let's go to the next slide. Dear listeners, let's discuss neurocutaneous diseases. We'll start with so-called tuberous sclerosis. Tuberous sclerosis presents with several clinical signs and symptoms. This is neurosurgical abnormality, such as seizures, progressive psychomotor retardation, slowly progressive mental deterioration. Also presents with skin signs and symptoms, which includes adenoma sebaceum, which is basically redundant facial nodules, chagrin patches, which is literally plaques on the trunk, and ash leaf, which is hypopigmentation patches. Also presents with retinal lesions, and also presents with cardiac rhabdomyomas. And we have to know that there is no specific treatment. We have to just control the seizures. On figure 10/7 is presented a case with lesions of neurofibromatosis, which are flesh covered, soft, and non-tender. Let's talk about neurofibromas. Neurofibromatosis, which is so-called von Reichenhausen disease. This clinical situation presents with few signs and symptoms. Number one, neurofibromas, which are soft, fresh-covered lesions attached to the peripheral nerves. Also presents with 8 cranial nerve tumors. Number 3, cutaneous hyperpigmented lesions such as café au lait spots. And number 4, meningioma and gliomas. We have to know that there is no specific treatment. 8 cranial nerve lesions may also need surgical decompression to help preserve the hearing. In case of Sturge-Weber syndrome, patients present with the following. Number 1, port wine stain of the face. Number 2, seizures. Number 3, CNS, homonymous hemianopsia, hemiparesis, and mental subabnormality. We have to do a skull X-ray, which shows a calcification of the angiomas. There is no specific treatment beyond controlling the seizures. Let's go to the next slide, which is slide 25. On slide 25, let's discuss so-called essential tremor. Essential tremor occurs in both rest and with intention when we're trying to reach things. The tremor is greater in the hands, but can affect the head as well. The examination is otherwise normal. The tremor may affect some manual skills, such as handwriting or computer use, keyboard. Caffeine makes it worse. And the best therapy for essential tremor, that's propranolol. There is a clinical tip here which states that the tremor in rest and except exertion improves with drinking of alcohol. It's a key for diagnosis. Let's discuss Parkinson. By definition, Parkinson is a loss of cells in substantia nigra which decrease the dopamine, which leads to significant movement disorder presenting with tremor, gait disturbance, and rigidity. So if we have patient which has tremor, gait disturbance, and rigidity, that's a typical Parkinson. Etiology. There is many causes for Parkinson, which is important for you to remember only the ones which help the answer what is the most likely diagnosis of the question. For instance, gait disturbance with a history of repeat head trauma from boxing or use of anti-psychological medications such as Thorazine can help establishing of diagnosis. Other causes are encephalitis, reserpine, metoclopramide. The most common cause of Parkinson, that's idiopathic. Slide 26. We continue discussing Parkinson. There is a clinical tip which states that there is no test for Parkinson. The diagnosis is entirely based on clinical presentation. And how presents Parkinson? We need to look for a patient which is 50 or 60 years old or older, which has a tremor, muscular rigidity, bradykinesia, which is slow movement, and shuffling gait with unsteadiness on turning and tendency to fall. Also, there is a cogwheel rigidity in the slowing of the movement of passive flexion and extension of extremity. Facial expression is limited, so-called hypomimia, and writing is small micrographia. Postural instability is orthostatic hypotension. This happens because of the same slowness that results in bradykinesia, result in instability of the pulse or blood pressure to reset approximately. When unaffected person stands up, the pulse speeds up within seconds. This is impaired in the Parkinson, which lead to lightheadedness when getting up from a sitting position. There is a clinical tip here which states that the most frequent Parkinson question is the treatment. We need to know the Parkinson drugs. And the treatment is the following. Anticholinergic medications like benztropine and trihexydyl. This relieves the tremor and the rigidity. It is unclear why blocking of acetylcholine improves the symptoms of insufficient dopamine. Adverse effects of dry mouth, worsening prostatic hypertrophy, and constipation frequently occur in older patients. Amantadine may work by increasing of the dopamine from the substantia nigra. definitively the answer of all patients above 60 which are intolerant to anticholinergic medications. So patients which are older than 60, we can use amantadine. If the disease is severe, which in this case the patients are not able to care for themselves, and there is orthostatic hypotension, we need to use dopamine agonist like pramixeprazole and ropinidol, which are the best initial treatment for Parkinson's disease. The last medication, which is ropinirole, is an alternative. Let's go to next slide, 27. This slide discusses the medication in treatment of Parkinson. Carbidopa-levodopa is the most effective medication. It's associated with on and off phenomena which result in episodes of insufficient dopamine or off, the dopamine is off, which is characterized by bradykinesia. The on effect is too much dopamine, which results in dyskinesia. COMT inhibitors like tolcapone and entacapone, they extend the duration of levodopa-carbidopa effect by blocking of metabolism of dopamine. Use these medications only in these cases when patients are treated with carbidopa-levodopa. Use when there is on and off phenomena to even out of the dopamine level, or when the response of therapy is not enough or inadequate. Also, we can use MAO inhibitors like rasagiline and selegiline as a single agent, or adjustments to levodopa-carbidopa. They block the metabolism of dopamine. And also we can use deep brain stimulator, which means that electrical stimulation is highly effective for tremors and rigidity in some patients. Also, there is a clinical tip here which states that we need to avoid tyramine-containing foods as a cheese with MAO inhibitors. They precipitate in hypotension. And here there is two clinical questions, samples of two clinical questions. The first question is, which of the following is most likely to slow the progression of Parkinson? A, pramixazole, B, carbidopa-levodopa, C, rasagiline, D, tolcapone, and E, amantadine. The right answer is C, and explanation is that only the MAO inhibitors are associated with possibility of retarding of the progression of Parkinson. Our next clinical question is, we have a 70-year-old man with extremely severe Parkinson comes by ambulance to the emergency department, secondary to psychosis and confusion which develop at home. He is maintained on levodopa, carbidopa, ropinirole, and tolcapone. And the question here is, which is the most appropriate next step of management? A, stop carbidopa, levodopa. B, start clozapine. C, stop ropinirole. And D, stop tolcapone. Let's start with slide 28, and the last is E, start haloperidol. The correct answer here is B, and the explanation is very simple. When a patient has very severe Parkinson, you cannot stop medication because of the patient can become locked in severe bradykinesia. Psychosis and confusion are well-known side effects of anti-Parkinson treatment. Use antipsychotic medication with few extrapyramidal or anti-dopaminergic effects. There is two clinical tips here which state that Lewy body dementia, this is same like Parkinson with dementia. And the second one is Shy-Drager syndrome, is the same as the Parkinson, predominantly with orthostasis. Let's discuss here spasticity. Painful contracted muscles from damage of the central nervous system is called spasticity. Spasticity is often associated with MS. No single treatment is universally effective. We can do baclofen or dantrolene, and central acting alpha agonist izanidine may work, all of them. Next topic is restless leg syndrome. Patients which report an uncomfortable sensation of the legs, which is like creepy or crawly at night. The discomfort works with caffeine. It's relieved by moving of the leg. This can happen during sleep. A patient sometimes brought by a bed partner who is being kicked at night. All right. Treat with dopamine agonists such as pramipexole. Next topic is Huntington disease. Huntington disease, or HD, is a hereditary disease characterized by CAG, trinucleic repeat sequences of chromosome 4. Let's go to the next slide. Slide 29. When the question asks, what is the most likely diagnosis? HD is the answer when you see number 1, choreiform movement disorder or dyskinesia. Number 2, dementia. Number 3, behavior changes such as irritability, moodiness, antisocial behavior. And number 4, the onset is between ages of 30 and 50 with family history of HD. The movement disorder of HD starts with fidgetiness or restlessness, which progressive development of dystonic posturing, rigidity, and akinesia. Clinical tip here states that movement disorder may be troubling in HD, but it is far worse to progress to no movement at all or rigidity. What kind of diagnostic test and treatment we can do? Okay, so there is no specific genetic test for HD. It is 99% sensitive. I'm sorry, there is a specific genetic test for HD, which is 99% sensitive. CAG trinucleotide repeat sequences are found on genetic analysis. The symptom triad as a memory, movement, memory, mood, or three M's, movement, memory, mood, is confined by a test. No treatment reverses HD. Dyskinesia is treated with tetrabenazine. Psychosis is treated with haloperidol, quetiapine, or a trial with different antipsychotic. We need to remember here that head CT MRI shows a caudate nucleus involvement. Let's talk about Tourette syndrome, TOURETTE disorder. Tourette is the idiopathic disease of, number 1, vocal cords, grunts in coprolalia. Number 2, motor tics such as blinking, frowning, sniffing. Number 4, obsessive compulsive behavior. Let's go to the next slide. There is no specific diagnostic test. It's treated with flufenazine, clonazepam, and Pimozid or other neuroleptic medications. Methylphenidate or ADHD treatments are increasing in Tourette management. Let's discuss next topic, which is MS or multiple sclerosis. This is an idiopathic disorder exclusively on a CNS, brain and cord white matter. MS is more common in white women which live in colder climates. When the question asks what is the most likely diagnosis, we need to look for multiple neurological deficit of the CNS affecting any aspects on CNS functioning. The most common presentation is focal sensory symptoms with gait and balance problems. Blurry vision or visual disturbances from optic neuritis is no longer as common as the first presentation. After optic neuritis, the most common abnormality is motor and sensory. The most common abnormalities are cognitive defect and dementia. Sexual functions remains relatively intact.
internuclear ophthalmoplegia, or INO, is inability to adduct one eye with nystagmus of the other eye. INO is characteristically for MS. Other findings are fatigue, spasticity in hyperreflexia, and 3 is cerebral deficit. The diagnostic test for MS includes MRI, which is both the best initial test and the most accurate test. Number 2, lumbar puncture, or LP, which shows CSF with mild elevation of protein. Let's go to the next slide, 31. And fewer than 50 to 100 WBCs. Oligoclonal bands is found in 85% of the patients. Oligoclonal bands are not specific for MS. On figure 10/8, we'll see MS plaques appear white and exclusively in the white matter of CNS. We have so-called white matter lesions. There is a clinical tip here which states that oligoclonal bands are the answer is 3 to 5% of the patients with equivocal or non-diagnostic MRI. We need to know that visual and auditory evoked potentials are always the wrong answer. The treatment: high-dose steroids are the best initial therapy for acute exacerbation, and the steroids are shorten the duration of exacerbation. Let's go to the next slide, 32. Drugs which can prevent relapse or progression of MS. One drug, this is glatiramer or copolymer 1. The next drug is beta interferon. Number 3 is fungolimod, diethyl fumarate, and oral teriflunomide. Number 4, this is natalizumab. Number 5 is mitoxantrone. Number 7 is azathioprine, and number 8, cyclophosphamide. Patients which develop worsening of the neurological deficits with use of a chronic suppressive medication. The MRI shows new multiple white matter hypodense lesion. Which of these medications are most likely to cause this? This is natalizumab, which is inhibitor of alpha-4 integrin, and it can occasionally be associated with development of progressive multifocal leukoencephalopathy, or PML. Also, we need to remember that glatiramer and beta interferon are the best initial choices for prevention of relapses. Next is MRI. Next things we have to remember for MS, that MRI gadolinium contrast reaction. So if we have reactions to gadolinium contrast, which is less common than other allergic reactions or renal injury associated with iodine contrast material for CT scan. However, systemic overreaction to gadolinium can occur in increased collagen deposits in the soft tissues and hardening of the fibrotic nodules develop on the skin, heart, lungs, and liver. This condition is also called nephrogenic systemic fibrosis, occur only in renal insufficiency. There is no specific therapy. Let's go to the next slide. Here we will talk about motor neuron disease and amyotrophic lateral sclerosis. ALS, or amyotrophic lateral sclerosis. The etiology is unknown, but there is a loss of exclusively of upper and lower motor neurons. What is the most likely diagnosis? Is that we're going to look for weakness of unclear etiology starting at age of 20 or 40 with a unique combination of upper and lower motor neuron loss. The most serious presentation is difficulty of chewing and swallowing and decrease in gag reflex. This leads to pooling of saliva into the pharynx and frequent episodes of aspiration. A weak cough or loss of swallowing is often poor diagnosis. In ALS, there is no sensory loss or sphincter are spared. And here we have a nice table where we can see the difference between clinical presentation of amyotrophic lateral sclerosis for upper and lower motor neurons. For upper motor neurons, we have weakness, spasticity, hyperreflexia, and extensor plantar responses. For lower motor neurons, we have weakness, wasting, and fasciculations. All right. What kind of diagnostic test and treatment? Electromyography reveals loss of neural innervation in multiple muscle groups. CPK levels are elevated. Riluzole reduces glutamine buildup in neurons and may prevent progression of this disease. Baclofen treats the spasticity. CPAP or BiPAP help with the respiratory difficulties secondary to muscle weakness. Tracheostomy and maintenance on a ventilator is often necessary when the disease advances. Let's go to the next slide. Here there is a clinical vignette, clinical tip, which states that in ALS, the most common cause of death, that's respiratory failure. So-called CMT or Charcot-Marie Tooth disease. This is a genetic disorder with loss of both motor and sensory innervation, which is leading to number 1, distal weakness and sensory loss, number 2, wasting in the legs, number 3, decreased deep DTR or deep tender reflexes, number 4, tremors. Foot deformity is a high arch is very common. Pescavus. The legs took like inverted champagne bottles. The most accurate test is electromyography, and there is no treatment. Let's discuss peripheral neuropathy. The most common cause for peripheral neuropathy, this is diabetes mellitus. Other causes include uremia, alcoholism, and paraproteinemia like monoclonal gammopathy of unknown significance. The best initial therapy is pregabalin and gabapentin. Pregabalin or gabapentin. TCA or tricyclic antidepressants, and most seizure medications as a phenytoin, carbamazepine, and lamotrigine are effective in some cases. And there is a nice table here of some specific peripheral nerve neuropathy. We have from left to right the nerves, number 2, precipitating events, which describing the stem and manifestations and presentations, number 3. Let's go one by one. Move to slide 35. In this table, the ulnar one is usually biker, and there is pressure on the palms and hands, and trauma to the medial side of the elbow. There is a wasting of the hypotenar eminence, pain in the 4th and 5th fingers. In the radial one, there is a pressure of the inner upper arm, falling asleep with the arm over back of the chair, which is Saturday night palsy, usually crutches and pressure of the axilla. And there is a wrist drop. For so-called lateral cutaneous nerve of the thigh, we have obesity, pregnancy, sitting with crossed legs. We have pain, numbness of outer aspect of the thigh. Also, we have tarsal tunnel or tibial nerve, which worsens with walking, and then pain and numbness in the ankles and sole of the foot. And also we have peroneal, high boots pressure of the back of the knee. Also we have weak foot with decreased dorsiflexion and an eversion. On medial type of peripheral neuropathy, we have typists, carpenters working with lines. Also, we have thinner waist pain, numbness of the first 3 fingers. Let's discuss here the end of this slide, so-called facial or 7th cranial nerve palsy or Bell's palsy. The most common cause for facial palsy is idiopathic. Some identified causes are Lyme disease, sarcoidosis, herpes zoster, and tumors. The presentation is paralysis of the entire side of the face is a very classical sign. Stroke will paralyze only the lower half of the face because of the upper half of the face receive innervation from the both cerebral hemispheres. There is difficulty with closing of the eye. If the patient can wrinkle her forehead on the affected side, so if there is a difficulty with closing the eye, if the patient can wrinkle her forehead on the affected side, worry about stroke. If the patient cannot wrinkle his forehead on the affected side, it is a Bell's palsy. Let's go to the next slide. So GBS, or so-called Guillain-Barré syndrome, is autoimmune damage of the multiple peripheral nerves. By definition, there is no CNS involvement. Calculating the antibody attacks the myelin sheaths of the peripheral nerve and removing the insufflation. GBS is associated with Campylobacter jejuni infection. If the question asks what is the most likely diagnosis, we have to look for weakness of the legs, which ascends from the feet and moves towards the chest, which is associated with loss of DTR, or deep tendon reflexes. A few patients have mild sensory disturbances. The main problem is that when GBS hits the diaphragm, it is associated with respiratory muscle weakness. Autoimmune dysfunction with hypotension, hypertension, and tachycardia can occur. Usually, we have ascending weakness plus loss of reflexes, which is GBS. The diagnostic test is the most specific diagnostic test. This is nerve conduction studies and electromyography. This will be show of decrease of the propagation of electrical impulses along the nerves, but it takes 1 or 2 weeks to become abnormal. Dear listeners, let's talk about so-called acute inflammatory polyneuropathy, or Guillain-Barré syndrome. By definition, GBS, or Guillain-Barré syndrome, is autoimmune damage of multiple peripheral nerves. By definition, there is no CNS involvement. We have a circulating antibody attacks on the myelin sheaths of the peripheral nerves, which is removing the insufflation. GBS, is associated with Campylobacter jejuni infection. If the question asks what is the symptoms we're looking for, or what is the most likely diagnosis, we're looking for weakness of the legs that extends from the feet and moves towards the chest, and it's associated with loss of DTR. A few patients have a mild sensory disturbance. The main problem is when GBS hit the diaphragm, it is associated with respiratory muscle weakness. Autonomic dysfunction with hypertension, or tachycardia can occur. So the clinical tip is here that a straining weakness plus loss of reflexes is GBS. Diagnostic test, the most specific diagnostic test is nerve conduction study or electromyography. This will show decrease in the propagation in the electrical impulses along the nerves, but it takes 1 to 2 weeks to become abnormal. Let's go to the next slide.